Thank you for the opportunity to present today at SAGES. Hold it. Oh, okay. Sorry. Our team members, research team members, have no conflicts of interest to disclose. Stray energy is or unintended energy transfer is a very important concept in surgery. It's there's a release of stray energy essentially in all minimally invasive cases. Essentially, all instruments, whether they're intact or not, can cause unintended thermal injury. And there's still very little data regarding stray energy transfer in robotics. We have done some previous studies that have explored these topics in ex vivo models. Here in this trial, we chose transabdominal periperitoneal inguinal hernia repair, as this operation essentially can't be done the same way laparoscopically and robotically. We chose the same source of energy, a very common four-strand Covidian generator set at a 30-watt coag. And then we assess the injury. And here, as a kind of a proxy for injury, we chose to take skin biopsies around the three different ports: the camera port, the assistant grasper, and an energized working port. And then we stained the samples with Picker series red stain, which can identify thermal injury. Our trial essentially included about 40 patients who were randomized in two different groups, and about 19 completed the robotic arm and 17 completed the laparoscopic arm. The socio-demographic data of our patients was pretty much the same. Same as our surgical data. The blood loss and a couple quantifiers for surgery and operative times were very, very similar in both arms. And also comparing the patients' outcomes post-operatively, they were very similar. Most of our patients did very well. We had very few complications. And as to the actual analysis here, so the samples were taken with a stain with Picker series red, and basically the way this stain works is under polarized light, it looks at collagen specifically. And collagen that has been injured through thermal injury will have this kind of grayish, greenish kind of appearance, as you can see in figure 8. So when we looked at all of this, we saw that essentially there's really not that much difference between the two groups. We do see that majority of ports have some show thermal damage, about 50% of total, and we do see slight predominance of injuries at the robotic camera port, but there's no statistical difference there. So as to the whole discussion of this concept, stray energy transfer occurs during laparoscopic robotic inguinal hernia repairs. We can see with this study. Majority of the skin samples did show some signs of thermal injury. Mechanisms behind stray energy transfer, there's various ones: insulation failures, direct transfer, antenna capacitive coupling. The later ones are the ones that are responsible here. That's where actually energy can transfer through intact insulation across essentially jumps to surrounding tissues. Thermal injuries can occur at all ports, but camera port tends to be more affected than the lateral ports. Comparing to a previous study back from 2013, a similar pattern was seen in laparoscopic cystectomy. And then what's kind of interesting is that there's really no significant complications or clinical manifestations of thermal injuries in either group. In conclusion, stray energy transfer can occur in da Vinci inguinal hernias. Patterns appear similar to laparoscopy. More study is needed to understand the clinical significance of all of this. And then finally, it is of utmost importance that surgeons understand concepts behind stray energy transfer and these injuries, because fortunately they're rare, but they can happen, and participate in the fundamental use of a surgical energy program, inspection of all of your instruments, and one of the most important ones is to try to avoid open air activation as much as possible. Thank you.
Thank you, Dr. Wikiel. And in the interest of time, if you have questions for the rest of the presentations, if you could come to the presenters afterwards. We'll move on to the next presentation.
The next presentation is entitled Clinical Outcomes of Electric Robotic versus Laparoscopic Surgery for Colon Cancer, utilizing a large national database, and will be presented by Lucero Paredes.
Thank you. Good afternoon, everyone. My name is Lucero Paredes. I'm a general surgery resident from Maine Medical Center, currently completing a research fellowship with the National Clinician Scholars Program at Yale University. And I'll be presenting on our research looking at outcomes following robotic versus laparoscopic colectomy. I'm gonna also, oh, thank you so much. There we go. We have no disclosures. The views expressed in this presentation do not represent the views of the NIH, the U.S. Department of Veterans Affairs, or the United States government. The use of minimally invasive surgery has become an integral component of surgical care. Several studies have demonstrated the benefits of laparoscopic surgery versus the traditional open approach, including shorter length of stay, lower need for opioid analgesics, and fewer wound complications. With the advent of robotic technology, though, as we have seen, there has been a growing interest in understanding the potential benefits of this operative approach. Some studies have demonstrated robotic surgery associated with lower conversion rates, shorter length of stay, and improved ergonomics in comparison to laparoscopy. Nevertheless, there continues to be disagreement whether robotic surgery is associated with improved patient outcomes. Therefore, our study sought to provide an updated understanding of the current landscape of minimally invasive colectomy. Our aims are to describe the adoption of robotic surgery for elective colon cancer resection over the past 2 decades, and to compare postoperative outcomes following robotic and laparoscopic colectomy. Our hypothesis is that robotic colectomy will be associated with equivalent, if not improved, postoperative outcomes compared to laparoscopic colectomy. We conducted a retrospective study utilizing NSQIP data for the years 2012 to 2020. We categorized adults who underwent elective minimally invasive surgery as either robotic RC or laparoscopic LC based on NSQIP coding, including only those with an indication of colon cancer. Our outcomes of interest included mortality, complications, reoperation, operative time, readmission, and postoperative length of stay. For statistical analysis, we used Pearson chi-square test, the Wilcoxon-signed rank test, and inverse probability weighted regression adjustment. We performed a secondary analysis on right and left colectomies determined by CPT codes in order to further characterize anastomotic leak rates. In our study, we identified a total of 83,841 patients who underwent minimally invasive elective colectomy for colon cancer. 69,719 of these were performed laparoscopically, and 14,122 were robotically. The figure to the right demonstrates that robotic colectomy was found to have increasing incidence across the years, with the first logged case being in 2012, and by the final year of our study, approximately 1 in 4 minimally invasive colectomies were performed robotically. You can see, I apologize. Our study groups differed significantly from one another. Patients who underwent robotic colectomy were younger, male, non-Hispanic white, with higher body mass index, fewer comorbidities, and functionally independent, with a p-value less than 0.05 for all. You can see here our outcomes following inverse probability adjustment. We found no differences in 30-day mortality and overall complication rates across the 2 operative groups. However, we did find notable differences in the highlighted box. In summary, robotic colectomy was associated with higher anastomotic leak rate, 3.5% versus 2.6%, return to OR, 5.1 versus 3.6%, operative time with a difference of about 63 minutes, readmission rate, 8.8% versus 7.2%, as well as decreased length of stay, 5.1 versus 4.9 days, with the p-value of less than 0.01 for all. We performed a secondary analysis of anastomotic leaks adjusting for location of resection. We excluded cases where location was not specified or anastomosis was not performed, or if the patient underwent total colectomy. After adjustment, the anastomotic leak rate for right colectomy was comparable between approaches, with a rate of about 2.1 to 2.2%. However, this was not the case for left colectomies. The leak rate following laparoscopic left colectomy was 2.7%, with robotic left colectomy having an even higher leak rate of 3.4%. Additionally, we can see from the confidence intervals that robotic left colectomy was associated with higher leak rates compared to laparoscopic left colectomy. Our study includes some limitations. The retrospective nature of the study does not allow for us to fully ascertain biases that may have influenced which patients received robotic or laparoscopic colectomy. Additionally, specific surgeon or hospital characteristics are not available. Therefore, we were unable to control for operative volume or proficiency. However, we attempted to mitigate for these confounders by including such a large sample size and using inverse probability weighting analysis, controlling for year of surgery. In summary, our study found that robotic surgery is becoming more common and has comparable overall outcomes to laparoscopic surgery for colon cancer resection. Further areas of research include identifying which patients would benefit the most from this approach, as well as potential adjuncts to improve postoperative outcomes. Thank you very much.
Thank you very much. Just one really quick question.
Sure.
Over that time period between 2012 and 2020, how much did the percentage of cases overall done by MIS techniques change? Do you have that denominator? Like, a percent open versus MIS?
Yes, so I didn't include it in this slide, but instead of 25% in the final year, it was 19%, but it did go up each year. But if we include open cases, it then decreases it to 19%.
Okay, thank you very much.
Thank you.
And we've made it to the final presentation of the session, and thank you so much for your attendance today. We really do appreciate it on the last day of the meeting. The final presentation is by Dr. Bittner, Clinical Outcomes and Kinematic Data in Robotic Cholecystectomies.
Thank you very much. Yeah. Yes, thank you. Got it. Thank you so much. So I'm Dan Bittner. I'm happy to present our work here from New York and Northwell Health. So a couple relevant disclosures. Me personally, I did some consulting work for deep surgery last year, but more relevantly, this work is in collaboration with Intuitive Surgical, and several members are represented as authors. So one of the sort of fundamental analogies for our work in performance analytics in surgery is actually looking at sports. It's a personal interest of mine, but also just a useful analogy. Just in the same way that data scientists can look at the movement of a pitcher's arm, or looking at how Messi and Ronaldo plan their passes around the pitch. You can look at how a surgeon plans the operation, how efficiently they move, and how these things could be individually measured, broken down, and even, in principle, improved. So one of the best ways of doing this is using the intuitive data recorder, which takes track of something called objective performance indicators, are broken down into two categories, kinematics and events data. Kinematics are how and where something moves. Events data is what happens, energy activation, console distraction, etc. So we hypothesized that more efficient intraoperative dissection would be associated with more operative experience, and potentially even with postoperative well-being. So we looked at a data set of 56 robotic cholecystectomies, starting in March of last year, going into the spring rather. And then we're mostly interested in the two major phases of the operation, the dissection of callus and the dissection of the gallbladder off the liver. So the major endpoint here is in correlation with experience, and then for postoperative recovery, we're interested in immediate well-being. So we looked at the short form 36 score, which is shown here. I can see that it's broken down into two major areas, physical health and mental health. And then we just used simple univariate analysis with Pearson's. I had to compare the continuous variables. So this is just some preliminary data on indication. So these were all elective surgeries, for the most part done for either symptomatic cholelithiasis or chronic cholecystitis. A few other hodgepodge categories were included, but there was a healthy young cohort of 45 years of age with an average Charlson score under 1. Just some complications data was also included. Very few complications, really. 3 cases were unexpectedly admitted, and a handful had 30 and 90-day complications, which were of no consequence, including no bile duct injuries or unplanned conversion to open or transfusions. So more importantly, getting into the major data, so this is a comparison with operative experience since it was started to be logged. So you can see that these are 3 of the objective performance indicators. It's active time, so how much that hand is moving during a certain phase of the operation. This is during callus triangle dissection. You can see that more experienced surgeons tend to have less active time. They're moving less. Another sample of the data, this is from the dissection of the gallbladder off the liver. Again, negative correlation with more experienced surgeons showing less active time, and also something like less path length. So they move through the operative field less, and they also use fewer clutch maneuvers, fewer resets, and they're more efficient in general. This is a pictorial description of what I've just explained. Both phases that I've mentioned are shown. Callus is above, and dissection of the gallbladder off the liver is below. you can see that, it's basically an early surgeon in his or her experience shows that they have sort of more outlier movements. They're away from the main part of the operative field more. And then later in the experience, you can see that their movements are more restricted, are more focused. It's a good example of the efficiency. And then our secondary interest is really just showing, does this matter in general to the patient and how they ultimately do. So we looked at the SF-36 scores and compared them with some of the objective performance indicators. And here we showed that the main one that did correlate was camera movement. So the rate of camera movement actually tended to have better early postoperative outcomes with respect to well-being than lower. So we showed that several objective performance indicators could be used to differentiate surgeons early and late in practice. And then we also tentatively show that the rate of camera movement during the dissection may be involved in a better outcome and a better postoperative recovery initially for patients. So I think that it behooves me to talk about some of the limitations here. So one is really just a numbers issue with very few patients that completed the survey, only 10 of the 56. And then the other things that are a little less easy to explain are the lack of correlation between some variables. Camera movement and economy of motion, for example, don't necessarily correlate. And then I think finally it's just more generally what we value in these outcomes. I think there's a signal to noise problem in this data, and there's a convenience problem. So the most important thing, obviously, in this operation is that we just avoid bile duct injuries. We obviously had 0 in this cohort. So if we, had 10,000 cases, maybe we could look at that. But for right now, we're stuck with just the convenience of looking at something like how does the patient tell you that they feel after the operation? And I think that that's not necessarily the most important thing to think about. Thank you all.